Welcome to our discussion today on the AAC assessment process, and we're going to do an overview. My name is Pat Orant. I'm a speech-language pathologist in the Baltimore, Washington area. I do have a private practice, and I have been working in the area of AAC and assistive technology for the recent number of decades. We won't say the exact number of decades. We're not into double digits yet. Anyway, before we begin our talk today, let me just please let you know that I am receiving financial compensation from ASHA for this presentation. As well, with regard to non-financial disclosures, I am in the immediate past president of the United States Society for Augmentative and Alternative Communication, as well as I have been on the advisory board for the Rehab Engineering Research Center on Communication Enhancement for the recent 12 or 15 years or so. So let's get to really the meat of why we're here today. We're going to talk about the AAC assessment process. And what I want to do is, I want to talk to you about the concepts, but I also want to use more video and case studies so that you could maybe see examples of what I'm talking about, for the only reason of we're not going to learn the whole process in 30 minutes. But as a speech-language pathologist who understands language, who understands speech production, anyone can do an AAC assessment. Everyone thinks the issues are, oh, I don't have the equipment in my lab, in my office, in my department. And there are ways around that problem. And all of us know from information that we've been receiving from ASHA over the recent years and decades, and information we see day to day at work, and that is we are running into individuals who rely more and more on augmentative and alternative communication strategies. So we'll start our discussion today just by saying it's a bit of a balancing act. You don't just go out and say, like you're buying a car, oh, I want that green one over there, or my friend's grandson's cousin had one that looked like that, so I want that, and that's not how we do it. We don't do it, oh, a vendor came in and said, I'd like this one. That's not the way we do it either. We have human beings with communication. And you know, Don Johnson has said communication, we all have our own fingerprint. We all communicate differently, but we all communicate. So we have this aspect called human factors, what I as the human need factored into this situation. And then we have equipment or technology that has features. And so we're going to try and do a balancing act of what the individual needs and what the technology brings. And we're going to approach it from an individual-centered approach. I'm going to start with a video of Jean. I need to point out that no one is ever going to need an AAC assessment unless they have a severe expressive communication disorder. And so we would be talking about aphasia, aphonia, apraxia, dysarthria, a severe expressive communication or mixed receptive expressive language disorder. So short of having one of these diagnoses, we're not going to need a communication device. Let me show you just a little bit of Jean, who is an individual that presents with both apraxia and aphasia. And we'll start with Jean. Go.
I'm so proud of you.
I'm so proud of you.
Good job.
Good job. Good job.
How
does work?
I need to talk.
I
Need to talk. Talk?
yes.
Talk about comedy.
Talk
Talk and
about
out Farley.
School.
School.
Softball.
Ball.
Cheer.
Feed.
feed,
Feed.
feed.
Okay.
Fi.
Fi,
Five.
Fo.
fo, fo, fo,
Foo.
foo, foo,
Look again.
foo. Great, okay.
Food.
All right. can just
So we just saw a video of Jean, and you'll see that there are a couple things that I wanted to bring forward in that video. The individuals that we work with are that. They're individuals. Jean is a mom, she's a wife, she's a friend, and everyone needs to be involved in that. Jean's goals for AAC are going to be long-term communication. You saw what her speech and language skills are. Now, I will say, after the integration of an AAC device, actually a variety of strategies, as well as formal speech language therapy, Jean's communication has improved significantly. And so we've actually done, when we want to talk about the goals of AAC, Lyle Lloyd and MacLean Fristow back in 1977 identified the goals as a temporary means of communication. So say somebody's in an ICU, somebody's been intubated for some reason, someone needs a way to communicate for a short period of time. That doesn't mean minutes or hours, maybe days, maybe months. Once again, it all depends on the individual and the circumstances. Other goals of AAC are for long-term means of communication, and as I said, that's what you're going to be experiencing with a patient like Jean. Although we also used the therapeutic implications of AAC in that it was helping to facilitate the development of her natural, or the redevelopment of her natural spoken communication system. As well, we have additional goals that our assessment really needs to keep in mind. Individuals need to be able to communicate personal self-care needs, emotional status, I'm happy, I'm sad, I'm frustrated. There's so many, the continuum of emotions. Need to engage in social communicative interactions with familiar communication partners, such as family, friends, close neighbors, but also carry out communicative interactions within the community. So when you go to the doctor, when you go to bingo, when you go to church, when you go to the bank, when you go to your granddaughter's baseball game, or when you go to your wife's whatever, basket party, I don't know. You need to be able to communicate no matter what the environment is. So in order to approach this process, we have to be somewhat systematic. We're going to first do an initial interview so we know a little bit about who the individual is. We're going to ask what the needs of that individual are. We're going to find out the individual's strengths as well as their limitations. That's not a negative thing. We just know what we need to kind of accelerate or support, and what we can rely on as part of our strategy. We need to know how the individual is going to access or control their communication device. Hopefully, we're going to have an opportunity for the individual actually to work with the device, so we can say, yep, I actually saw Pat use the ABC XYZ. Often, when I write up the report, I have a still shot of Pat using the ABC XYZ. So the funding source, whether it's a school system, whether it's Medicare, whether it's somebody's credit card, whoever's paying for this AAC device or this strategy, this system, knows that the individual did hands-on with it, was actually successful. And hopefully I have some data in there that says Pat was able to blah, blah, blah. Anyway, then we kind of do together a final system analysis. We purchase it, and then you always have to follow up. We have to remember that we started communicating out of the womb. We came out, we cried, we started eating, boom, we've been communicating. And we were supported through that process. I'm preaching to the choir here because everyone knows. But we have to do the same thing when a person is using augmentative or alternative communication strategies. Now, as I mentioned, the first step of the process is to find out something about the individual. So your basic demographic information, background information about education, work, anything you can find out about the individual. Interview the caregiver or whoever the communication, the familiar communication partners are. Observe the individual, because you're going to find out as we go through this discussion that not everything is going to come to you as a clinician in the form of a standard score. In fact, very little is going to come to you in the form of a standard score. And we're so used to saying, oh, patient X was able to achieve a standard score of with a mean of. It's not going to happen in your AAC assessment. We will be able to bring in some of that information, but as I said, client observation as well as interviews with others, background information, their demographic information is going to be information that is really forthcoming. We also need to know what the person needs to communicate. And so spoken communication, and as Asha has published for years, written communication is as viable. And then, off the record, Pat Oren, speech language pathologist, herself, nobody else, talks about control of the environment. So whether you're using something to turn on the lights or open the shades, or goodness gracious, do email or maybe look at a video, all of that is interacting with your environment and communicating. So we need to find out what kind of environments is the person going to be in. And you'll see some examples of this. Are they going to be side lying in bed? Are they going to be sitting upright in a chair? Are they going to be on the T-ball field? Are they going to be on the playground? Are they going to be on the MTA? You know, where are they going to be communicating? One of my biggest pet peeves is devices never go into the cafeteria of a school. They never go onto a school bus. But when are kids allowed to socialize and talk? In the cafeteria and on the school bus. But anyway, that's my little soapbox. I'll jump down off of it. We want to know who the communication partners are, not just familiar listeners, but unfamiliar listeners. Is that going to change? So if you're a consultant as your job, and you're on the phone a lot, and you're calling here and you're communicating there, all of that is possible, but we need to know those sorts of things. Versus you're a first grader and you stay in one class all day and you stay with that class and you have the same set of communication partners. What kinds of messages are you going to be communicating? Is it going to just be single words? Is it going to be word combinations? Is it going to be songs, poems? You're going to sing happy birthday? You know, and then once again, what modes am I going to use? Am I going to need to use something that has a keyboard and is wireless? Am I going to need something that has speech that we can increase the loudness? And we have to look at all this stuff. This is really the critical piece. So we know who the person is. We know what they bring as their needs, which that will change. What their needs are will change as their skills improve, or as in some cases, their disability or diagnosis improves or destabilizes, if you will. So we want to look at the person's cognition, their language, their motor skills, and their sensory skills. In no order, but we have to look at all those things. So, being the person I am, I generally list them in alphabetical order in my reports, just because that's how I do it. That's not the way you have to do it. But we're going to look at those 4 areas. When I say we're going to have to look at those 4 areas, there needs to be a team here. The team is not just the speech pathologist and the individual. It's their family, medical staff if involved, teachers, social services, audiologists, neurologists, related service teachers, your related arts teacher, your PE teacher, your adapted PE teacher, your anybody that is involved with you can be part of this team. And no longer, back in the 80s, I didn't say that word, back in the 80s, we would all sit around a table and do this. Today, we're not going to sit around that proverbial table and do this, but we can send emails, we can scan stuff, we can fax stuff, we can take pictures with our phones and send all that information forward. And I'm going to back up one more time. When we look at these 4 areas, I want you to think of a table in front of you, and all of this information is just thrown on the table. So we have the initial interview, we have the needs assessment, we're going to get cognitive information, we get language, motor, sensory, throw it all there. We don't know what our puzzle looks like because it didn't come in a box with a picture on it. But after we put all this stuff on the table, hopefully we're going to know. So as I said, we're not going to always have formal data. With regard to cognition, if we can get formal data, phenomenal. If not, then we want to talk about what we've seen. In some cases, because I work frequently with patients with ALS, I will get a neurologist report, and I'll be able to say, orient its time, space, and whatever it is, time, space, person. I'll be able to say, neurologist says language learning intact. Boom, I'm done. Not really, but I'll at least get that in there. The other thing we need to do is we need to look and watch the person. So I want to watch this video for just about a minute or so. And I'm going to start by saying, look at this young woman who has a significant motor impairment. That's quite obvious by looking at her. I want you to watch this video. On the other side of it, we're going to talk for a brief second. But while you're watching it, if you would just jot down everything you see that this young lady does, and then ask yourself, how can I put this into the cognitive or cognitive linguistic section of my report? Because all of this is going to fall into a written report. or a generated report of some sort. So once again, look at this picture. On the other side, we'll talk for a brief second.
I want you to see what happens when you press this switch. You have to watch the robot and do this switch over here. See, it opened it? Now do the other switch on the other side. See how that closes it? Okay. Open. Open. Close. Open. Close. Okay. Now, what do you think that one does? That turns it that way, and do the other one. That didn't do anything. Yes, it does. There we go. Okay. Now, put it back in the middle. Turn it back to the middle.
We're going to talk now about what you just saw. I think you're going to find this young lady was able to follow verbal task directions. Immediately, she understood temporal concepts. There were a whole host of things that I'm sure you wrote down. Another vignette, this young woman was in another scenario. This is Dr. Albert Cook from University of Alberta in Alced. He did the same activity with her in a larger group, and you see all those dolls lined up on the table. The other activity, they had her in a park, the table, they made it into a little park, and they said, you know, pick the yellow one up and put her next to the bench. And she picked the white one up and she put it over on the side. And they said, oh, she don't know what she's doing. Put the pink one up and put it near the tree. And she put the pink one, you know, over on the table. Ends up, she hadn't followed any directions. But her mom, one of the team members, was in the room and said, you know what she just did? She set those up using that robotic arm in chronological order from the date that Disney distributed those dolls. So year order. So what does that tell you about her temporal concepts, about math? What does that tell you about her ability to say, I'm not going to put it next to the tree. I prefer to let you know what I really know. Same thing with language. We watch what a person does. Sometimes it's going to be something like yes, no reliability, ability to follow verbal task directions, comprehend a conversation, recognize symbols. What kinds of symbols? Are we going to use objects? Are we going to use photos? We can use line drawings, written words. You can fill in. This is not a complete list. We could, when we talk about pictures, so often we see these grid pictures, but you got to remember, we're talking more about visual displays these days and things like that. To the right is a keyboard. So we have icons with text on the left. We have a keyboard, and the letter is a little funky here. They're all there. This is a keyboard from Enkidu years ago. I absolutely love it. Statistically arranged from the center out with word prediction, and then you see in the bottom a page that links to numbers, another button, if you will, that links to phrases. Two very different individuals are going to use these approaches. We're going to look at an individual. This is Chip. And originally Chip had a device similar to the Chat PC, I think this is, that we see here. He predated the Chat PC, whatever the first version of it was. And you're going to see him using that in the next video. And once again, just watch and take some notes.
Chip, can you tell me time for dinner? Can you tell me time? Can you clear it? Clear it. Chip, tell me time for dinner. Chip, tell me. Can you say time for dinner? There you go, good clear.
Time for.
Oh, for what? Do it.
Dinner.
Yeah! You like that?
Now we're going to look at Chip and his father on his own. Remember, team members. Dad, again, was salient in this process. I had just delivered this equipment to Chip earlier in the day. Dad took the video you just saw. You're going to see a video now where now Chip is using a keyboard. And you'll hear Dad say, so this is 5 minutes after I had him into. Dad realized, hey, maybe I can get some information about his use of letters, because Dad knew his son.
This is just 5 minutes later when I've added him into the alphabet page and asked him to tell me time for dinner by spelling it out. You got to see how excited it was when he figured it out. You got it?
Time.
Yeah, it did say time. Time what?
Time for dinner.
Yeah. Good boy, Chip.
Now here's another example of a keyboard. This is picture word power with a QWERTY keyboard and predicted words. Could somebody use something this complicated? Absolutely. Somebody can use letters. Somebody can use 3, 6, 9, 12 location. It all depends on the individual. You're going to take all this data down, some of it using actual devices, some of it using materials that you have in your office or in your lab. And then once again, we write all that down. Was the person able to locate target messages by searching or navigating? That would talk to us about their ability to do associations, categorization, sequencing. Can they combine? If they can they combine icons with text? So they can say, I want to go to, and then type out the park. You know, can a person do that? The question is open-ended. Whatever the person can do, throw that information on the table. The next area is motor, and range of motion is really important. We're going to look at range of motion, and the other area is access. Now, the reason I want you to look at this video is this is a young woman who has sustained a brainstem level stroke, is minimally verbal, almost aphonic at this point, but we're getting more progress. But I want you to see 6-8 months ago when she was assessed, she could only use a switch with her right hand. I'm using my left, but with her right hand. And the issue was, if we go back to the needs assessment, her need and the needs of her husband and her kids and her sisters and her mom, and her dad, and all of her family, very close, they were all Apple people, okay? They didn't want Windows, they didn't want Android. Fine, that is not a problem. The problem is this woman could only use a switch, and finding an app that works in an Apple environment wasn't the easiest thing to do. I will say, fortunately, the speech pathologist before me had that rough road to hoe, and she did it very successfully. And fortunately, the case got turned over to me, and now you're going to see this woman using a wireless mouse. And so we're going to watch this video, and I want, once again, for you just either mentally or physically to write down notes about what you see in this video, and you're going to throw that on the proverbial table. Keep moving your hand for me. Beautiful. Do it some more. Let me see everywhere your hand can go on that mouse pad. Yeah, keep it moving. Up. Good work. Good work. Bring it down. Yes, 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 yes. Over to the little, you were reading my mind. And up. Up. Beautiful. Perfect. Perfect. So you can see that she was able to move the entire width of the mouse pad. We're going to try and change the size of the mouse pad. We are also going to try and, well, you can see in that video, I don't want to misspeak here, she was using my Windows computer because she did, while her AirBook was in for repair, agree to use my Windows with my wireless mouse. But we're trying to get all those things better optimized, because in her case, the biggest issue was we have language intact. Cognition is intact. We'll get to sensory skills, but the anatomic site or the action that she was going to use, we have to make sure that a person has good range of motion. We have to look at what their speed is. We have to look at how they can be consistently accurate while being comfortable, with volitional control, with limited involuntary reflex, and if some degree of force needs to be applied. So for example, I tried a variety of mice with that woman, and I needed to at one point I tried one where she used her thumb. That didn't work because she had more force in her right index finger, and that was comfortable. So we found a mouse. And so those are the sorts of things. I'm going to talk a little bit more about anatomic sight down the road when I talk about positioning. So when we talk about positioning, and you saw, I talked about how in this case the mouse was on a mouse pad and it was wireless. But I also said that a few months ago she was using a switch, a microlight switch on her right hand. So we need to understand that positioning changes. You see the round thing in the middle of the screen. It changes. It changes based on what? It changes based on the status. So in this case, this young woman got more ability, return in her right upper extremity. It changes based on the environment. So you'll see a picture of that in a few minutes, but look at, this one was sitting upright in her manual wheelchair with a desk lamp, but what is she when she's lying supine in bed? Is she going to be able to control that right hand? So we're going to have to look at that. It also depends on the technology. Like I said, I'm not picking on Apple, but they didn't have really great strategies for using scanning packages or apps, whatever we want to call it. But it was her dedication to either Mac or iOS. And so that played into some of the information that we needed to consider. Now, so I talked about, see here where I talked about their status, the environment, the technology, and that all of this can change. It can change based on a variety of things. So we said back in the very beginning, a person is going to present with a severe expressive communication disorder. Many of the times, that is going to be secondary to a primary medical condition. All right, and whether that primary medical condition is a traumatic brain injury, a CVA, Lou Gehrig's disease, spinal muscle atrophy, muscular dystrophy, a cognitive impairment, autism spectrum disorder. I mean, we can go on. The list is thousands and thousands and thousands of possibilities. The status based on that primary medical condition can change because the condition can improve or the condition can continue to degenerate. So when we're doing our assessment, we need to take that into consideration. As I said again, the environment, and some of that is dictated by the needs assessment and by the initial interview, the technology. Let's look forward at this picture here. We have a picture of a young woman who was in a motor vehicle accident at the age of 8. So we see this young woman, she's not sidelined. She actually is sidelined. She looks like she's supine. She's lying in bed. She had an injury that was essentially at the brainstem. So I look at it as a high-level spinal cord injury. She doesn't have any control of her neck muscles, which is why you can see she has this cushioning around her head. She has a sheet that's holding her head in place. You can see her hands are lying next to her. The only muscle she can control is the lower lip. So when she's in bed, we had to put her with a switch. Once again, the microlight switch, it is one of my favorite switches. And she had to go on a scanning system. Look at this positioning. This is the same woman upright in a wheelchair with a Whitmire headrest and headband. You can see that now she is using her lower lip to control a mini joystick, which means now she has control of the entire computer. Now this was about 150 years ago, and so what she was using was a system we don't even have around now. It has a monitor here and a monitor here, and her keyboard was on this monitor and her documents were on this monitor. Point was, she could control them. This young woman graduated from high school on time and went on to college, online of course, because she's very limited in the environments that she can find herself. But the point was, positioning made it for her, as well as the technology. So we've talked about cognition, we've talked about language, we've talked about motor skills, we've talked about the initial interview, the needs assessment. We're going to go into sensory skills now. Simple, right? Vision, hearing. Well, yeah. Consider the communication partner as well as the individual. Provide any other subjective information you can. Now, I'm going to throw this little bomb into the confusion here. This is a patient of mine who had cortical basal degeneration, and so he was working with a neuropsychologist at Hopkins, and I was a speech pathologist on the case. And it ends up, remember I was talking about, can a person see icons? Can they see text? This individual's visual, they call it audio-visual awareness deficit. When he saw the letter B, it looked like a letter B. When he saw the number 8, it looked like that scribble you see underneath. He called it a bowl of spaghetti. This is really important to know because text, icons, numbers. Here's the case in this guy. He's a geological engineer, so he works with numbers. Ends up, his neuropsychologist came up with a system of depicting numbers so that he could see them using line drawings. My point in throwing this out is individuals present with all kinds of visual issues, whether it's a ptosis, whether it's nystagmus, whether it's acuity, whether it's macular degeneration, whether it's, what do they call this? AVAD. What did I say it was? Something visual awareness discrimination. There's only 2 other people that are known in at least our country with this, but you may present with somebody in your office. Same issue with auditory skills. Consider what the individual's auditory skills are, as well as the auditory skills of the communication partner, but also what's going to be necessary in environments. So when you're talking one-to-one with your spouse or a parent or a friend versus you're at the rec center or you're at the mall or you're giving a speech, all of that changes the auditory component in that you need to be able to hear the speaker from the communication device in those environments, as well as you better be able to physically hear or have your partner physically hear. So all of this stuff that we've been talking about, all of this is just the bottom line. We put all of this stuff on this proverbial table that I talked to you about. The needs assessment with the initial interview, all the data that you collected, no matter how formal or informal it is. You've tried devices. I always say, excuse me for hitting my mic, rule of thumb, no fewer than 3 devices. Talk about all 3. If you can do 5 or 6, that's good. And then you rule everything out. You go, I'm recommending XYZ because A, B, C, and D, E, F didn't work. Whatever the case is. You do all of this in a written report. And what I used to feel like is when a person read my report, they didn't think that they would necessarily want to fund this device, then I hadn't written my report properly. Either I hadn't made that picture so clear with the data that I had collected, I hadn't illustrated what the needs of that individual were. It was in my written report. The other thing I want to point out here is, and we talked about it a little bit when we talked about the goals of therapy. So now one of the goals is either the short-term or the long-term communication. We talked about therapeutic implications of AAC too. So in my written report, I'm also going to want to write not only what the widget looks like. Okay, the widget is called whatever it's called, and the supporting technologies. But I'm also going to want to write whether a person needs training in the setup and use or the programming, or if the person is going to be able to use that communication device to assist with the redevelopment of natural speech skills or the development of natural speech skills. And we know that the literature strongly suggests that integration of an augmentative communication system is very useful in the development or redevelopment of natural speech skills. And so we want to write that into the report too, because we need to make sure that once the widget or the device is recommended, that appropriate support services are in place. Because you know what? If you can't use the widget, if you didn't get these support services, there's no point in having the widget. There's no point in having the device. So I used to, years ago when I used to write for assessments for the Division of Rehab Services here in Maryland, and I'll tell you, back in the 90s, the state of Maryland paid for over $1 million worth of augmentative communication devices. This is in the 90s. People say they can't get communication devices. I can't believe it. There are written communication systems, there are spoken communication systems, but when I would write a report, I would say, here's your widget. Recommendation number 1 is purchase widget, whatever it's called. Recommendation number 2 was whatever I thought therapy or training was necessary. Recommendation number 3 was, if you can't do 2, don't bother doing 1. So if you can't provide the support services, don't buy the device because it's just going to collect dust. And as professionals, it's my signature going on that document. It's my signature that a doctor is going to read, and I'm going to say that this individual with ALS, or this child with cerebral palsy, or this 40-some-year-old woman with a brainstem level CVA is going to be able to communicate. I need to have everything kind of cinched up in this written report. So there are plenty of resources out there. I mean, my resources, I have a million years of experience. There are plenty other resources out there. So there's the aacfundinghelp.com. That actually has a report coach in it. aactechconnect.com has a feature matching aspect to it. The patient-provider communication website has a whole host of different devices and strategies. And then the AAC RERC on communication enhancement has publications, and they have web-based presentations. There are a whole host of resources. So good luck with your efforts moving forward. I think that that all of us are going to be doing AAC assessments and feeling very, very comfortable moving forward. Thank you.